We are here at the 19th World Congress on Controversies in Obstetrics, Gynecology and Infertility, Professor Stratis Kolibianakis. He is the Assistant Professor of Obstetrics, Gynecology, Assisted Reproduction at the Aristotle University of Thessaloniki. Professor Kolibianakis will talk about women with decreased ovarian reserve and strategies to improve the response to treatment. What are the reasons behind the lack of response to treatment of ovarian stimulation?
Well, the most frequent reason for not having a proper response in ovarian stimulation is an underdosing of the patient, which means that we have not chosen the appropriate dose for that patient based on the usual methods to do that, which is the number of antral follicles and the level of AMH and FSH. Second reason is that the patient cannot respond in any dosage, which means that the number of follicles left in the ovary are now too few to have a proper response. Or the FSH endogenous level is too high to be surpassed by the exogenous FSH we administer.
How do we implement therapies effectively to improve treatment response?
Well, the first step is not to adapt any treatments which are unproven, because then you end up with a long list of treatments and you don't know really what is working. The only proven interventions that can increase ovarian response in poor responders today is the co-administration of growth hormone and the pre-treatment with androgens. These are the only treatments that have been shown to have some benefit in these patients.
What is the management for excessive ovarian response?
Now, if on the other hand the response of the ovaries to exogenous stimulation is excessive, so we are now on the other side of the spectrum, then today we have tools who can save the patient from a very serious complication, which is known as ovarian hyperstimulation syndrome. So the appropriate management of these patients to avoid or to manage an excessive ovarian response, if this occurs, is to be able to administer, instead of ACG for triggering final oocyte maturation, GnRH agonist. The prerequisite for that is to keep the endogenous LH suppressed by administering GnRH antagonist. So in this case, the chance that ovarian hyperstimulation syndrome occurs is virtually zero. So we have no problems with excessive ovarian response.